I think the most inspiring part of this field is that I am certain things will change over the next 20 years, that we are not going to be doing the same things in 2045 that we're doing today. And I, in my own career, have been fortunate to witness evolution. I feel really inspired when I sit with patients that I can tell them with absolute honesty that what we do today will not be the same thing that we do 10 years from now and 10 years after that. And that you, as a patient suffering through this and as a family member, are going to be part of the change for the coming generation.
Welcome, everybody. How are you all today? I want to talk about tribes, conversations, change makers. Conversations matter. We need to take a crowbar and pull up the old nails of word of mouth and standing still. We need to pull them out, throw them aside, and start anew. In this day and age, a person can make a video or have a conversation that reaches millions of viewers. One person. That's all it takes. One person has everything they need to build something far bigger than ourselves. People will hear the message. They'll follow. They'll become change agents if we start something. Seth Godin told a story at a conference that I had attended about a man named Scott Beeler. Scott had attended the South by Southwest conference. He was an innovator, a leader, a business owner. At the conference, he was waiting in this really long line to get into the Google party. After waiting nearly an hour, he decided to leave. He'd had enough of waiting to hear somebody else's words, somebody else's inspiration, somebody else's thoughts. He walked down the street to a deserted bar, grabbed some tables, set them up in the back, grabbed his phone, and fired off a bunch of social media messages saying, Alta Vista party at Ginger Man. Within a few minutes, 8 people showed up. Within an hour, 50. Shortly after that, there was a long line waiting. People out the door, waiting to talk to him, to hear his words, to be part of his tribe. It's not a political movement. It's not a walkout. It's not a rebellion. It's a tribe. It's energy. It's connection. You multiply this by thousands or millions across the internet, and you've created something really special. Tribes can turn into movements, and movements are powerful. They're positive. They're change-making. That's what these conversations are all about. It's about a tribe. Gay Monglio is a tribe. When we have conversations about brain cancer, innovation, new treatments, grief and loss, hope and love, we have energy. We've created movement, positivity for all of those out there who are losing hope in cancer research and funding, in getting better, in not feeling so alone. They're losing hope in our system, in our current political landscape. And part of today's tribe includes our guests, Dr. Andrew Brenner and Dr. Toral Patel. They will join us after a brief word from one of our sponsors. Do you want to be part of our tribe? Follow us on socials. Spread our message, spread our word. Or you can consider donating to Gay Monglio and help us continue creating change-making conversations. Join us. Be part of our tribe. And when we come back, we will sit down with Drs. Brenner and Patel and talk to them about exciting new clinical trials and treatments they have right here in our own backyard. We'll be right back.
This season of the Gay Monglio podcast is sponsored by GT MedTech and Gametile Therapy. Learn more at gametile.com. This season is also sponsored by MVAX, personalized whole tumor-derived immunotherapy. Learn more at mvax.com. This episode is sponsored by Cypress Therapeutics. Chemistry is the core of our innovation. Learn more at cypresstx.com. This episode is sponsored by Cortana Pharma, developing highly targeted therapies for brain cancer. Learn more at cortanapharma.com.
Welcome back, everybody. Thank you so much for joining us. It's hard to believe that we're actually getting into towards the end of our season here on Game on Glio, and I couldn't think of a better way to start rounding things off as we go into season 6, which we will be back for, thank God, and I'm so excited to say that. In the meantime, as we get ready to go in towards the end of the year, we have 2 amazing, really innovative and wonderful doctors with us today, and I'd like to introduce them to you now. The first is Dr. Andrew Brenner. He's a neuro-oncologist, medical oncologist, and tumor biologist with a focus in drug development for the management of primary brain tumors and breast neoplasms. His interests are in developing novel therapeutics for the treatment of malignancy with a focus on overcoming resistance to conventional therapeutics. And I can't stress that enough because we really need that. He's a clinical investigator and neuro-oncologist at the Mays Cancer Center at UT Health San Antonio, Texas, and he's currently enrolling patients for the ReSPECT-GBM and ReSPECT-LM clinical trials. Alongside of him is our guest, Dr. Patel, who is an assistant professor at UT Southwestern Medical Center. It's a nationally ranked department of neurological surgery. She specializes in brain tumor surgery and has won numerous awards, including the William F. Collins Resident Research Award, the Louis E. Goodman Award, and the Johns Hopkins University Department of Biomedical Engineering Undergraduate Research Award. That's a lot to say. She currently holds a patent titled Highly Penetrative Nano-Carriers for Treatment of CNS Disease for her research into how nanoparticles can be used to carry drugs directly to the site of brain tumors. And I mention it because this is the goal. This is what we're trying to do. This is exactly where we're trying to get to when it comes to combating brain tumors. So thank you so much, both of you, for joining us today. I can't wait to dive into this conversation.
Thanks for having us.
Thanks so much for having us.
So I want to throw this first question to both of you. You know, we're talking about neuro-oncology, neurosurgery, brain tumors, CNS tumors. This is not an easy field. It is intense. It is excruciating. Sometimes, a lot of times, you don't have the outcomes that you really would like to see. So why did each of you enter this field? What drove you guys into this particular cancer treatment cause? I mean, both of you going into neurosurgery and neuro-oncology, why? And whoever wants to start can jump right in.
Okay, I'll start. So I actually started off as a tumor biologist. My dad had cancer when I was in high school, and that I think was a primary driving force for me want to explore it. And when I was doing my undergraduate degree in biochemistry, I had some really great mentors who really got me stimulated in research. So I decided I was going to pursue my PhD, and I did that in tumor biology at MD Anderson. And during that time, I was really mainly studying breast cancer. And so when I went into my clinical training, I thought I was going to be a breast oncologist. I knew I was going to go into oncology, but I wanted to do more than just research. I wanted to take care of people as well. But when I was in my training, one thing became really apparent, and that is that there is a huge discrepancy between how patients do with some cancers and how they do with CNS cancers. And repeatedly, we kind of get into this situation where there really wasn't any great clinical trials or anything really exciting happening for the brain tumor patients. And I was like, this seems like a real opportunity for me to make a difference. So I just basically started huddling all the brain tumor patients in my clinic all to me, and just kind of took it over, and we kind of rebuilt the neuro-oncology program at our institution.
Wow.
So.
That's amazing. What about you, Dr. Patel?
Yeah, I too, like Dr. Brenner, had some family experiences with malignant tumors of the body and also of the brain. And so I think hearing that message from my parents growing up about family members, including their own parents who had lost battles with cancer, was probably the initial seed or kernel that inspired me as a young person, but perhaps in my subconscious and something I wasn't totally aware of. But I was always called to medicine, this idea of using science and empathy to affect the lives of others in a positive way. And so when I went to medical school, I think there's a very early on in medical school, students will tend to gravitate towards either patients who are really sick or patients who are really well. And we need doctors to take care of both populations, patients who are well for preventative health care and patients who are sick, who need really acute interventions. And so when I was in medical school, it became clear to me that I um, uh, did best or enjoyed most taking care of those who are really ill. And then eventually found my way to neurosurgery through a series of really excellent mentors. And then when I was in neurosurgical residency, I had a really amazing mentor in neurosurgical oncology, and his work and some work that I did in lab studying nanoparticles for drug delivery. And then I'm sure the subconscious effect of knowing many of my family members had cancer, and specifically brain cancers, all sort of coalesced into a career in neurosurgical oncology.
So let me piggyback on that and, ask you, what is it that intrigues you about these advancements that are being made currently in cancer care, these innovations and novel treatments that are coming up? What is it that intrigues you so much about this?
Uh, well, it's always interesting because being involved in oncology, you get to see what's happening across the entire spectra. I remember a time when we were managing melanoma patients, and they'd present with brain metastases, and it was almost like, gosh, there can't be anything worse. And then we started having checkpoint inhibitors and targeted BRAF inhibitors, BRAF MEK inhibition. I remember when Jimmy Carter was treated, it was like, oh, he had melanoma metastases, right? And people were asked, well, what's the prognosis? Well, it's not great. Well, he was one of the first with immune checkpoint inhibitors, and look how long he survived. It was really just transformational. And we've seen that with other cancers as well. And so I think for our brain tumor patients, it's just a matter of time. And we have to keep plugging away. And I can't tell you for sure where it's going to be coming from, but the amount of different research that we have ongoing on, whether it's our work in convection and delivery, target radiotherapeutics, or whether it might be for CAR T or dendritic cell vaccine, or something is going to change outcomes pretty dramatically for our patients. I can't tell you exactly where it's coming from, but there's a lot of different areas of work that are ongoing, and it's just a matter of time before glioblastoma and other tumors like that become like melanoma brain metastases were.
Love to hear that messaging. Dr. Patel, what about you?
Yeah, I want to echo Dr. Brenner's thoughts. I think the most inspiring part of this field is that I am certain things will change over the next 20 years, that we are not going to be doing the same things in 2045 that we're doing today. And I, in my own career, have been fortunate to witness evolution, for example, in the treatment of low-grade glioma patients, to be a part of the initial IDH inhibitor therapy trials for phase 1, phase 2, then the randomized control trial, the Indigo trial, and then to see that published in the New England Journal of Medicine, and then to give that message of hope to patients in clinic. And that's, something that's happened perhaps in the first third of my career. And so I am certain that there's going to be more of that. I feel really inspired when I sit with patients that I can tell them with absolute honesty that what we do today will not be the same thing that we do 10 years from now and 10 years after that. And that you, as a patient suffering through this and as a family member, are going to be part of the change for the coming generation.
That's amazing. Messaging like that is so vital and so important to our tribe, to the people that need this messaging and need this hope right now, because it's an uphill battle, but it's one we are taking head on. And Dr. Brenner, I want to ask you specifically, when you say tumor biologist, what does that mean exactly? So to all those who are listening that don't understand, the different nuances and directions that we can go in when it comes to being in the medical field, does this mean, that you're really looking at the DNA, the fingerprint of a tumor? Is that kind of what a tumor biologist means?
To some degree, I mean, being a tumor biologist means I study how the actual underlying mechanisms of how these tumors grow. They start, grow, and adapt, and that can include how they learn to resist certain therapies and basically trying to find weaknesses that we can exploit. There's a lot of different ways of doing that. We've come a long ways with, from initially sequencing DNA, RNA bulk sequencing. Now we're moving to things like single cell sequencing, where we get the fingerprint of each individual cell, both at the expression level and at the DNA level. And then we're moving on to newer things like CyTOF-based imaging, where we can look at proteins specifically within individual cells, and we can create a huge mountain of data that provides for not just knowing on average what the tumor looks like, but really how all the individual cells within a tumor looks like, because these tumors tend to be very heterogeneous.
Mhm.
So when we are looking at trying to understand how these tumors grow and how they become resistant, we're really kind of using all these approaches, whether it's at the DNA level, RNA level, protein level, the microenvironment level, how the immune cells interact with the tumor, and how the surrounding normal cells help to support the tumor's growth. All that is kind of within the domain of tumor biology.
So let me follow up on that really quickly. So when you're talking about single cells, focusing on single cells, looking at the different DNA, the different makeup of the different cells of the tumor, would it be wise or knowledgeable to say that in looking at, we're talking about brain cancers specifically here, but, even with CNS cancers, which are just a whole other arena. Um, but, I've heard before, and I've talked to different patients and other um, profiling oncologists that look at the makeup of a tumor. And when you're doing this, does that allow for different immunotherapies and different combinations of treatments to be used in the attack against the brain cancer, so that you're targeting all the different types of makeups of the tumor to possibly give the patient a better chance? I mean, is that part of the reasoning for this?
Yeah, I mean, we are obviously trying to move from a one size fits all type of therapy to precision therapies that target the biology of that individual's cancer.
Okay.
Um, we in some instances we are, a lot of the clinical trials are moving in that way, actually finding specific antigens or specific things that the immune system can latch onto for a given tumor.
Mhm.
From the biology standpoint, I think we're kind of taking it actually a step back away from the patient, where what we're trying to do is understand how the different cells all interplay with each other. For
Yeah.
example, if you do the typical gene profiling, we get certain answers like, yes, there's a overexpression of epidermal growth factor receptor, which is very common at 50 to 70%. But once you try and treat a tumor, which are the cells that are actually emerging, and
Mhm.
what are the actual phenotypes of those cells, or what is the makeup of those cells that are actually the ones that are able to grow out from a treatment? And so, how do we stop that at the very beginning before those cells grow out? So it's kind of trying to understand the biology as well as applying it to the individual patient.
So, Dr. Patel, let me throw this one over to you. You focus a lot in nanoparticles and have a patent currently for a potential um, treatment modality, I guess, let's say, for specifically in dealing with brain cancer. How important is it to be focusing on these type of treatment options to break the blood-brain barrier when it comes to because we hear it time and time again that it's so hard to get treatments to the brain because the brain does such a great job of protecting itself because that's how we're built, that's how we're born. But when it comes to brain cancer, we need to be able to break that blood-brain barrier. So how important are options like this and patents like the one you currently have for treating brain cancer?
Yeah, I mean, I think this is a critical point of importance, obviously something that both Dr. Brenner and I have spent a lot of time thinking about. And it comes from the idea that, many of these cancers you can cure in the lab. If you grow them in a petri dish, even if you grow them in a small animal, you can cure many of these cancers. All the cells die. But then if you give that same therapeutic to a human being, you don't get the same result. And why is that? Well, there's many, many reasons behind that, but one such reason is the blood-brain barrier. And you're right that our body developed that um, by design so that every time we get the common cold, we don't end up with meningitis.
Right.
But when you have a tumor or a cancer in the brain, that obviously proves a potential and very potent barrier to getting effective therapeutics into the brain. And so I have an engineering background, and that's why I spent some time during residency in lab studying drug delivery techniques. And one such technique is using nanoparticles to encapsulate a drug. And then you can deliver those nanoparticles a myriad of ways. In the Rhenium Respect trial, we put catheters directly into the brain, and then we used a special technique that uses a pressure gradient and something called bulk flow to push those nanoparticles through very tiny catheters into the mass of the tumor. That's one such technique. Other techniques involve coating nanoparticles with really sort of stealthy, next level targeting moieties. And then you inject those nanoparticles intravenously like you would a typical chemotherapy. And then these special coatings of the nanoparticle help it to move through the blood-brain barrier. And so there's various ways to get a nanoparticle into the brain. But the idea behind a nanoparticle is that it's a class of devices called drug delivery devices in which you can encapsulate a drug that we know to be really potent in lab that will kill a tumor in a petri dish, but somehow can't get into the human brain effectively. And this is a carrier that can help us to do that.
So let's open this up a little bit because, as we're talking about innovation here and we're talking about really breaking down the ways to treat brain cancer and how far we've come. It's also important, because we have clinical trials. Clinical trials help you guys figure out the best ways to treat. How do humans respond? Just like you're talking about, we can do this well in a petri dish, but then we get to, or, in animal studies, but then we get to the human level and all of a sudden we're coming up against these barriers. Well, this is what clinical trials help us do, is figure out those nuances and problem solve around them. So Dr. Brenner, let me ask you, why is it so important for us to have multi-centered studies for clinical trials?
These type of studies are critical because they ensure the results are real, that they're reliable and generalizable. If you have a study done on only one hospital, you risk that it's going to reflect a single population as well as a particular practice style. Brain tumors are rare and heterogeneous, so, we really need collaboration across multiple institutions to recruit enough patients. So that's one thing, but also to include that it's a just diverse demographic, that it is not just a group of patients from my clinic, for example, and also to prove that works in different settings. If the expertise is only applicable to one institution and it can't be done anywhere else, then any findings out of that is really going to be not applicable to our general patient population. So we really need to make sure that what we do is really effective across multiple different sites.
So, we're talking about different clinical trials. One such trial right now is Respect GBM and the Respect LM trials. Can one or both of you kind of touch base on what this trial is? I know that Plus Therapeutics is heavily involved with this, and this is a multi-centered clinical trial that's currently recruiting. What is this trial and how can it help either leptomeninges with spread to the CNS, or when it comes to brain cancer like glioblastoma, how can this trial be used to help against those?
Well, I can speak a little bit about what it is. Basically, we have been using radiotherapeutics to treat cancer for a large number of years. For example, thyroid cancer, one of the most
Mhm.
impactful things that we do is radioactive iodine. And the reason that radioactive iodine works so well is because it's actually taken up by the thyroid gland and it sits there where the cancer is, and it is able to treat at very high doses in a very small place. With the problem with the brain is if we inject radiotherapeutics directly into the brain without some type of carrier, it just rapidly gets picked up and dumped by the kidneys or dumped by the
Mm.
liver. So it doesn't really stay in the tissue. So you need something to really cause it to be kept there in the tumor so that the tumor can be exposed to the very high levels. And so a what the Rima abysmabomida is it's really a molecule that was custom designed to grab the radioisotope and allow it to enter into the little tiny liposomes. The liposomes are about 1/1000th the size of a cell, but they're made
Wow.
up. Yeah, they're made up of the same stuff that the cell's wall is made up of, which is basically DSPC. It's a type of lipid and cholesterol. And so these tiny little liposomes are able to be chock full of the radiation. And then when we administer it into the brain, the particle size, well, that seems really, really tiny to us in terms of for the brain structure. Those are actually much larger than the typical small molecules that we're using, like chemotherapy. So the liposomes aid in the dispersal through the brain tissue. And then on top of that, once it gets there, it gets locked in. Those
Okay.
liposomes get taken up by either the cancer cells or the surrounding normal cells that are responsible for in that microenvironment there. And the radiation just sits there and it just decays as part of its normal half-life. So the rhenium abysmamida really is a way of delivering and trapping radiation within tumors to give very high doses.
So, Dr. Patel, I'm assuming that you're involved with this clinical trial as well. Have you used this clinical trial with your patient population? If you have, what are you seeing with the patients who have entered the trial?
Yes. Well, I have enrolled patients in both trials, the Respect GBM trial and the Respect LM trial. Many patients, in fact. And I think um, we published the results of this work in the last year, and clearly, for the GBM patients, for the glioblastoma patients, if you can get a high dose of the radiation into the tumor, and there's a threshold dose by which future trial design is being planned, but if you can get above that threshold dose, patients live longer. Now, ultimately, we will need to vet these results in larger trials, and that work is ongoing to plan that. But it is clear that there's a signal there that for those patients who receive above a threshold dose with a very, very high level of radiation, something that you could not deliver by either straight radiation injection, as Dr. Brenner said, or
Mhm.
via external beam radiation, the traditional radiation that glioblastoma patients get, because the toxicities would be too high.
Right.
But if they can get above that dose with this nanoparticle approach, they live longer. And for the Respect LM trial, this is for patients who have typically some type of systemic cancer, breast cancer, lung cancer being common ones, with metastases to the leptomeningeal space. That's this
Yep.
tiny microscopic space between the surface of the brain and where all of the sort of fine lining of the brain lives, and that's called the subarachnoid space. When you have metastases to that space, it's not like having a metastasis to the substance of the brain where the metastasis is a solid round ball. You can see it, you can target it, and that's the only cancer. This is microscopic cells that are all over the nervous system. And so you need a strategy that will mimic the biology of that leptomeningeal spread. And so injecting something like the Respect LM nanoparticles into the spinal fluid and then having that circulate throughout the whole nervous system, that very well matches the biology of what leptomeningeal disease does. And we have certainly seen some promising early results from that trial. we need to complete the trial and do formal analysis. But that's typically a condition in which the average survival is measured in less than a few months. And we have some truly outstanding patients who have had responses that were previously unheard of, living years with their disease. And so we're very hopeful, although certainly need to wait for the full analysis to make any formal statements there.
When it comes to finding better treatment options for these patients, we hear more and more stories, pediatric cases, young adult cases. I mean, not even sure what's going on or why we're seeing so many young adults with brain cancer, but it's pretty astounding the number of stories that I keep hearing about. How important is it to both of you, and Dr. Brenner, we can start with you and move over to Dr. Patel, but how important is it to have patient first, patient-centered care and advocacy when tackling these kind of issues? How can oncologists do a better job of being patient-centered?
Yeah, I think that means listening as much as we talk, understanding not only the disease, but also the individual's goals, their fears, trying to understand what's important to them in terms of quality of life. Advocacy is about making sure the patients have access to trials, to new therapies, and clear information so they can make informed decisions. So we always can do a better job by slowing down, involving the patients, the decision making, and remembering that compassion is as powerful as any drug we give. So all those are really important in terms of our day-to-day job, especially when we're dealing with brain tumor patients.
And what about you, Dr. Patel?
Yeah, I really very much believe in this idea of shared decision making. Gone are the days in medicine of a really strictly or strongly paternalistic approach where you come in and you tell the patient what they need and walk out and assume that all is well. The truth is that these are really very difficult decisions for patients and families to make, and especially for those who are dealing with these conditions at a young age, and quality of life matters. And so what a 25-year-old chooses in terms of the aggressivity of their care or not will be different than the average 50-year-old, which will be different than the average 75-year-old. And understanding and meeting your patient where they are in life and what their goals are is important. And so the young person may wish to reduce toxicities because they still have young children to raise or work that they want to continue to pursue. And the older person, and we're generalizing, the older person may say, well, I can take a little bit more here up front because I don't still need to go to work every day. And so to really just sit down, listen, as Dr. Brenner said, take a step back and ask your patient and their family, what are your goals for this treatment? What are the best things that I can do for you? And then tailoring a treatment plan that meets that.
Thank you so much, both of you, for such astounding information. I have one more question, and I ask this to all of the neurosurgeons and oncologists and doctors that I talk to, because I think it's vital to also humanize the work that you guys are doing. You guys are human beings that are on the front lines of defense when it comes to dealing with these kind of really rare and hard cancers to battle. And even though you've had all of the training and you are the experts, you guys are also human beings. And so in doing this kind of work, how do you both decompress after work? Given the field that you're in, at the end of the day, how do you decompress and stay balanced so that you can still continue to do such a great job for the patients that you work with?
Well, I'd say for me, I mean, there's a couple things that I keep as non-negotiables, and one of those is family time. Being there for my family is really important to me, and it helps me kind of reset. And then exercise is another thing. I would be remiss if I'm sitting there telling other people to take care of themselves when I'm not doing that to myself. So I think as doctors, we also have to be models in terms of that. When I'm not spending all my time running my kids around or taking care of family, I try and enjoy wine and food. I have an Italian background. I used to make wine, but I don't have time for it anymore. Once fun. But I do love to travel and to visit with family members as much as possible. And I do try and, for all of our trainees, fellows and residents and students, I do try and show that you can have resilience through balance, not just endurance. It's not just about plodding through without any type of rest or anything like that. You can achieve your goals by maintaining some balance in your life. And that's a good, I think, example to set for others.
I like that. My mom will be really happy to hear that because I come from a very Italian background. So food is the center of everything in my family. So, but I think that's so important. And, Dr. Patel, I want to hear what you do as well. But I do think that tapping into passions, not just working out or being healthy, to be models, but also having things that you're passionate about outside of work that you can tap into, because I think that is the only way to keep us sane in a world where things can get very stressful and chaotic, and keep us in that zone of chaos quite often. So I do think that having passion for things outside of the work that you do brings in that balance. So, Dr. Patel, what about you? How do you decompress and stay balanced so you can keep treating your patients?
Yeah, it's a busy life, and
Yeah.
it would be silly to think that I can check all the boxes every day. And for many years, I loved running. I ran a marathon in medical school, and then people would ask me, "Oh, do you still run?" And I would say, "Oh, I ran 26 miles that day, and I haven't run 26 miles in total since." But all of that aside, taking care of patients with these tumors really gives you a lot of perspective and a lot of thanks for your own physical, mental, emotional health. And so I have a young family. I try to spend a lot of time with them, and it really helps to put things in perspective for me when I'm home and taking care of my family. I really do love running, and I fortunately started running again, and it it makes me so thankful that I have a body that is listening to me and that will do what I want it to do. And I know that that might not be forever. And I see that every day. And so I'm trying to be very mindful of that and to appreciate that. And then I also love gardening. I mean, it's harder in Texas than it was on the East Coast. Everything here
Yes.
either burns or freezes. Yes, there's a very narrow range of things that you can grow, but I love it, and I love to plant things and to see them come to life. And whether it's a flower or food, there's a real joy in seeing something grow and develop through some consistent effort and nourishment. And so I think it's just an important life lesson, frankly.
It sounds like there's a running theme for that, because as neuro-oncologists and neurosurgeons, you have to have patience with the work that you do. And it sounds like you've picked gardening, which also is a test of patience. Yeah, I think that that's great. I used to be a runner as well, and my knees started hating me. So I turned to cycling and said, okay, if I can't run, I'm going to cycle because I need something outdoors. And I'm so thankful that you guys are able to be, open about it and not guarded about it, because I think it humanizes, you guys as the doctors and the experts to all of those who do watch and listen the show. It humanizes you guys and shows that we're all on the same level playing field. It's just that we each have a different journey that we're taking in this life. And the ones that you guys are taking are that of helping and giving back in a very unique field and space, healthcare wise. And there's those of us who, ended up being personally touched by it, that go into the media space and the public speaking space and advocacy. And then you've got people on the patient side that are battling this and trying to understand the dynamic. So, we're all in this together. We are a tribe together dealing with this. And I think that your leadership and the positivity that we have around this messaging is just so crucial. So thank you so, so much. If anybody wants to learn more about these trials, where can they go, Dr. Brenner? Where can they go to look up the information for these trials if they're interested in possibly being a candidate?
Well, they're all listed on clinicaltrials.gov, but also there's the Respect Clinical Trials website that they can go to, and just by searching Respect LM or Respect GBM, you'll be able to find that.
Okay. Thank you guys so much. I will have both of their bios and information about both of these doctors up on our website, and it's respect-trials.com. You can go there to learn more about both of these clinical trials. Thank you guys so much for your time today. It was such a pleasure to talk with both of you and give this information to our audience.
Thank you so much, Shannon.
Thank you, everybody. And with that, we will be right back.
This episode is sponsored by Brockport Custom Carpet, your flooring destination in Brockport, New York. Learn more at brockportcustomcarpet.com.
You've been listening to the Game on Glio podcast, the podcast that is designed to educate, advocate, and tell the real stories of those walking the journey of brain cancers such as glioblastoma and grief and loss. Like what you hear? Share us with others. Follow us on Instagram at Game on Glio Podcast, Facebook at Game on Glio, or visit our website or YouTube channel. You can find us anywhere podcasts are played.